Good evening, everybody. Welcome to this evening's CLL Advocates Network Plan webinar. Thank you for joining. Just letting you know the meeting is being recorded, so I have now pressed OK. So tonight's webinar is on the topic everybody may or may not be before they've seen about the webinar, that the European Hematology Association, the EHA guidelines for the management of chronic lymphocytic leukemia, and within the title it also touches as well and included in there the rare transformations, Richter's transformation. So this webinar really is about discussing the advances in the guidelines, to explain key elements. What do these guidelines mean for the clinicians that are treating? What do they mean for the patients? And we'll also touch on a unique element. This is the first time that patients and patient advocates have been involved in the writing group and the review groups. So just to let everybody know, we are going to have a 30-minute presentation. We will have a panel discussion afterwards for 20 minutes, and then that will be followed by some questions from yourselves in the audience. So from an expediency point of view, after the discussion or during the discussion, if you have any questions that come out from the presentation or that come out from the discussion, just pop them in chat, and then we'll look to pick those up to be able to field to whoever the questions are most relevant for. So without further ado, maybe I should introduce myself and then hand it over to the rest of the panel to introduce themselves. My name's Nick. Many of you may have met me before. I'm a CLL patient of some 17 years. I was the former chair of CLL Advocates Network. I still work with the Advocates Network. I work in the UK for leukemia care, and I've been assigned the role to chair the meeting this evening. So again, welcome and thanks for joining. If I could maybe hand over to you, Johannes, to introduce yourself, and then you can pass the parcel. Yes.
So my name's Johannes. I've been a CLL patient since 2020. I'm a vice chair of CLL Advocates Network and of many other patient organizations. I will pass on to Rita.
Hi, Rita.
Yeah, I'm Rita Christensen. I'm the head of LYLE. It stands for Lymphoma and Leukemia. We are working with CLL patients also. I have been in LYLE since 2007, so I know a lot about CLL.
Thank you, Rita. Hi, Anna. Over to yourself. We're having technical problems. I think you're on the other side of the world. We've got a heat wave here in Europe.
No, so I'm good. I think it's in the background. It's probably best if we manage our cameras and microphones ourselves. Anyway, so I'm Anna Schuh. I'm a professor of hematology at the University of Oxford, and it's a great pleasure to be with you here. I'm one of the co-authors of the guidelines, the EHA guidelines. So I will try and digest them for you, with you, in a way that hopefully you'll get something out of it, out of this session.
Thank you, Anna. Thank you for giving your time and preparing something for patient advocates and patients. We can see you now, Rita. Nice to see you. The person I'm looking for is Pierre. Pierre, are you with us? I cannot see him on my screen. Is anybody able to see Pierre?
Yeah,
he's just joined. Yes.
Yes. Excuse me, it was an interruption of my connection. My connection is extremely poor.
Yes.
Sorry.
Please introduce yourself, Pierre. We were just doing the round of introduction.
Okay. So I am. My name is Pierre Aumont. I am from France. I am a CLL patient. I've been a CLL patient for more than 15 years and now treated. I am a board member of ELI, which is the French association who is dealing with the CLL, and steering committee members of CLAN.
Thank you, Pierre. So just to add to everybody, I was also invited on as an author as well in the writing group, and everybody on the panel, that's Pierre, Rita and Johannes, were also involved as well with the review and commentary and inputs as well. So thank you for joining us, everybody. Maybe we could just, for expediency, hand it over to you, Anna, if you'd like to. So Anna's about to give a presentation, and if I let you give your presentation, and then we'll take a discussion afterwards.
Okay, great. I hope you can see the slides and
No,
you can hear me okay.
Yeah, they're on slideshow now. We can, yeah.
Okay, excellent. Okay, so as I said, I will run you through the EHA guidelines and tell you a little bit about the general gist, and then how the guidelines have been changed from previous guidelines. So first of all, I will go through how CLL is diagnosed, when and how CLL is treated, what happens if the CLL comes back, how you stay well with CLL, and then a little bit about the support that we can offer as doctors. So how is it diagnosed? Well, basically, most of the patients with CLL these days are diagnosed on routine blood tests. So they go to their general practitioners for unrelated reasons, and then they're found to have a high white cell count. That is then usually picked up by hematologists in the local hospital labs, who usually then say, oh, this could be CLL, but let's wait for 3 months and check again. And if it is then still have raised the white cell count, then there's a reflex test, flow cytometry, that happens automatically on the sample that was sent in, the second sample that was sent in. Why is this done in this way? Is because flow cytometry is quite expensive, and so we don't want to do flow cytometry on everybody with a high white cell count or high lymphocyte count, because most of the time when the lymphocyte count is a bit high, it's because of reactions, because of infection or virus infections and things like that. So the flow cytometry then makes sure that this is CLL and that it is not one of the many other so-called lymphoproliferative disorders, so other types of lymphomas that have circulating cells in the bloodstream. And it's also important, as already said, to make sure that it's not coming from a reaction to viruses or other infections. And we have funny markers, CD19, CD5, CD23. All these markers are surface markers on the cells that we can reveal with antibodies that are attached to colors. That's basically what flow cytometry is. So it's a very good test to confirm the diagnosis of CLL, but it doesn't tell you anything about the underlying prognosis and whether you will go on and have treatment or not treatment, and how you will respond to the treatment. So that's really where the genetic tests are coming in. And they are not genetic tests that look for inheritance, but they are genetic tests that look for changes that occur in the lymphocytes, in the lymph nodes, in the lymphoid organs of the immune system. So they don't occur in the sperm cells or in the ovaries. They occur much later on in life in the lymphoid cells. And then in CLL, which is different from lots of other diseases and lymphomas in particular, we do not do routinely CT scans. But I appreciate that probably a lot of you will have undergone a CT scan when you were first diagnosed, but it's not really required unless there's particular clinical circumstances. So I'm trying to advance the slide. There we are. So most patients who are diagnosed in this way, in fact, in the UK, we now know it's about over 2/3 of the patients, they will not need treatment straight away. And this is basically because we know from many, many studies over the last 40 years that if we start treating early stage CLL, that does not necessarily lead to improvement in outcomes. Yes, it pushes away the time to the treatment when the first treatment is needed potentially, but it's not really, or the next treatment is needed, but it does not help with prolonging life, even with modern drugs. And there's many studies in recent years, and this is also illustrated in the EHA guidelines. Even ibrutinib given early does not have any impact, any positive impact on overall survival. But because ibrutinib has got side effects, of course, patients who are usually would not have any treatment, they then get side effects. And that's why we are very reluctant as clinicians to jump in and treating CLL early. So most people go through this active surveillance stage. Of course, that is an important stage because a lot of people will worry at that point because they're being told they have leukemia, but no treatment is needed, which I think a lot of the time might be interpreted as there is no treatment or nothing can be done. And so this might worry people or will worry people a lot. And as doctors, I think we need to look out for symptoms of anxiety and depression. People, I've met patients in the past who sold their house and they did a trip around the world. They got divorced. They did all the things they always wanted to do because they thought it was nothing could be done. So it's important that we keep that in mind. Because it's normal to feel worried, but as doctors, we have a responsibility to reassure people. So when does the treatment then start, if it's not starting at the beginning? Basically, when either there are signs that the bone marrow, which is the part of the body where all the cells are produced, the red cells that carry the blood, the oxygen from the lungs into the muscles and into the brain, and the platelets that clot the blood, and the white cells also that fight infections. So if the CLL goes into the factory and stops it from producing all these very important cells, then that is clearly an indication for treatment. We are calling this bone marrow failure. If patients get very large lymph nodes or an enlarged spleen, especially if they grow fast or they are causing symptoms, then that needs treatment. A fast rising lymphocyte count with a doubling time of less than 6 months might need treatment. Autoimmune problems definitely need treatment. So when the body starts producing antibodies against red cells or against the platelets, then this needs to be controlled. And it can be a life-threatening condition that happens not infrequently in patients with CLL because their immune system is not working properly. And then B symptoms, weight loss over 10% of body weight within 6 months, fever, drenching night sweats, severe fatigue. If you have to get up during the night to shower, that is not normal. So those types of symptoms also are an indication for treatment. But before we start treating, and this again is something that is new in the guidelines, is we do need to do 2 tests. The TP53 test was there before. I start off with the IgHV gene status test. It's the immunoglobulin status. That's how we're calling it. It can be either mutated or unmutated. And in this case, when it's mutated, it indicates a more gentle disease, a slower progressing disease. When it's unmutated, it is more active. The CLL is generally speaking more active. We even now these days think about having two different types of CLL, one that is mutated and the other one that is unmutated. These results will never change over time. So it's enough to do this test once before your first treatment. There's also a lot of data, and my group will publish more data on this that suggests actually that this test can also be used in combination with other things, can be used to predict whether a patient needs closer monitoring or whether a patient can actually be very, very reassured and can be left alone. So well, left alone is the wrong word, but basically have very soft active surveillance, not intensive active surveillance. So, this test really indicates two different types of CLL. That's how I would like to look at it. And then TP53 is a bit different in the sense that TP53 in itself, when you test a diagnosis and you have it, it does not mean that you will need treatment more sooner or anything. But what it means is that your body really does not like chemotherapy. The CLL will be resistant to chemotherapy. And you might say, oh, this is not relevant anymore in the era of targeted therapies. But even in the era of targeted therapies, although they work really well against patients with TP53 mutation, against the CLL with TP53 mutations, but they don't work quite as well as when you don't have a mutation in TP53. So the other important thing to remember with this test is that it needs to be repeated with every line of treatment, because this one can change. You can acquire TP53 mutations as you have more and more treatment. Then there's also two main ways that CLL is treated today. And again, it's a bit different from the previous guidelines, where we only had venetoclax or obinutuzumab. We now, as a fixed duration, time-limited treatment, we now have many other combinations, and I'll come onto this in more detail. But we basically think about the time-limited treatment that is a fixed course, roughly over a year. Is usually includes venetoclax, but is often combined with other targeted drugs. And when the treatment stops, you can have a break for several years, depending on the underlying regimen that is used. So this is really becoming the first choice of treatment when it is available. The continuous treatment, which is the original targeted therapy, it's with ibrutinib or with acalabrutinib or zanubrutinib or pirtobrutinib, those types of treatments, you have to take them as long as it works. So this might mean that you're on drug for years and years, 5, 7, sometimes 10 years. There's no planned stopping point. It's a good option for some patients, and it's definitely the preferred option for patients with TP53 abnormalities. So how your treatment is chosen, I have to say, a lot of it's the point in the middle at the bottom, is your preference. Of course, I've already highlighted there are some indications. TP53, definitely, I would argue, patients should have continuous treatment. IGHV mutated, the ones with the slower disease, they respond really well to fixed duration therapy, to the point that we think that a lot of those patients are probably functionally cured when they get the fixed duration therapy. And that is because they might die of other causes, to be frank, but they will have very long-lasting remissions where they don't need CLL treatment. Yes, the CLL might be there in the background, but it does not cause any problems, and therefore they have a year of treatment, and then afterwards they're completely fine. Those are the mutated patients. So that's really the main reasons why we're doing those tests, is to identify the ones who will do really well with fixed duration therapy, and the ones who preferably should have continuous therapy. The other thing that plays a role is the general health. And I don't want to go too much into details, but the obvious example is if you have previous problems with heart disease, or you are on anticoagulant treatment, so drugs that thin your blood thinners, then maybe ibrutinib is not the best drug for you. Maybe even the second generation ibrutinibs, i.e. acalabrutinib, zanubrutinib, maybe they are not completely the right drugs for you if you have to take them for years and years and years. So your doctor will basically go through your medical history and will try and identify what is the best fit for your your body, and also for the other tablets that you are already on, in terms of drug interactions. And then, like I said, the preference and the ease to use plays a big role. So some of the fixed duration therapies, venetoclax, obinutuzumab, obviously it's very much linked to an antibody treatment that you have to have for a week. It's an intravenous infusion. You have to have it weekly for 8 weeks. This might not be something that people necessarily want to do. And so that's also where is one of the areas where the preference comes in, really. Now, when you're looking at the time-limited therapy in practice, we have obviously the older chemotherapy still there. We have venetoclax, obinutuzumab, already mentioned this, and then venetoclax with a BTK inhibitor. And you see that, the best responses are very good responses at 5 years. The disease will still be under control in 62% of patients on older chemotherapy, and over 80% with a fixed duration therapy. This is for the standard risk CLL patients. The continuous therapies, you have acalabrutinib and zanubrutinib, which are definitely now the preferred choice, because they have fewer heart-related side effects than the original drug ibrutinib. But for example, patients who started off on ibrutinib and who are still on ibrutinib, if they are doing well and they don't have any side effects, we are not going to switch them to a second generation BTKI. We will always keep them on the ibrutinib because it works for them. But we are not starting any newly diagnosed patients or patients who need treatment now. We would not start them on ibrutinib. We would start them on acalabrutinib or zanubrutinib. We would always do a heart health check. That depends a little bit on clinicians, how deep that check is, and it depends on your previous cardiac history. So going a bit more into the details, and so that's why I've copied now the schema directly from the guidelines. In the first time patients need treatment, we really have to differentiate between, number one, whether they are TP53, whether they have a TP53 abnormality or not, and then whether they have unmutated or mutated IGHV. And as I already said, with the DEL17P, we very much prefer continuous therapy. So this is either acalabrutinib or zanubrutinib. And there's very little evidence for or against the other. They are the same as far as doctors are concerned. As far as side effects are concerned, there's some evidence that maybe zanubrutinib causes a little bit more reduction of the good white cells, the ones that fight infection. Acalabrutinib definitely causes a headache in many patients for a few weeks until they get used to it. So there's pros and cons for either of them. They're not completely the same. And that's a good thing, because if one patient, for example, can really not tolerate acalabrutinib because of headaches or God knows what, then there's evidence that when you switch to zanubrutinib, that they will be fine, and so that there's no cross-reaction of side effects when they switch to another drug. So when we're switching because of intolerance, we can interchange them, and that's a good thing. But ibrutinib is definitely there as a second line because of the underlying, minor, relatively minor, but definitely more issues with the heart and bleeding complications. Now, we still mention also fixed duration regimen here. So the combinations of venetoclax with either obinutuzumab or acalabrutinib. And that is because there might be circumstances where we do need to go for fixed duration regimen, even although TP53 is affected. And that's not a bad thing. Patients respond well, but they don't. The response duration might only be like 3-4 years rather than the 5 or 6 years that you see in the standard CLL without TP53 mutation. And then there's a few others mentioned there. Venetoclax is a monotherapy, and idelalisib and rituximab. I think that's probably very rare that one would have to use those regimen. I can't think of many circumstances where that would be the case in the frontline setting anyway. Okay, so when you have standard risk CLL, so no TP53 abnormality, then the question is mutated or unmutated. So as I already said, mutated, you definitely go for fixed duration regimen. And the preferred ones really, you can toss the coin between venetoclax, obinutuzumab, and acalabrutinib plus venetoclax. As I already said, the obinutuzumab is given intravenously. You have to turn up at the clinic. It's an infusion weekly over 8 weeks and then monthly. There are infusion-related side effects that can be quite scary for patients. Acalabrutinib plus venetoclax is a really good alternative, and it's a completely oral medication, so you only have to take it at home. The same for ibrutinib and venetoclax. Now, in the fixed duration scenario, I'm thinking about the FLAIR study that we run in the UK. Ibrutinib and venetoclax as a fixed duration regimen is actually really well tolerated. We don't see these heart-related side effects that we saw with the continuous ibrutinib over years. We don't see them so much because patients are on it only for a year, not like for 5 or 6 years. But again, as you see now, we don't completely exclude giving continuous therapy with zanubrutinib, acalabrutinib in the mutated patients. And then in the unmutated patients, there is a preference for fixed duration therapy. But you see also that we're not definitely the continuous therapy is coming right after that. And that's really the area where I think is the grayest at the moment in CLL management, because the differences between in the time for the CLL to come back after treatment are not that much different. We're talking in the order of 5-year progression-free survival with fixed duration or with continuous therapy. So there's not that much difference between the two. And there has not been a randomized controlled study comparing the two, so it's kind of quite difficult. So what I should say, though, this is particularly for people listening in from the UK, is that the acalabrutinib venetoclax combination fixed duration has been rejected by NICE in the first round. And there is another now recommendation date set for the 19th of August. So we have to watch the space. At the moment, it is not recommended. And this is because we do have therapies for untreated CLL in the United Kingdom, including venetoclax plus ibrutinib, venetoclax plus obinutuzumab, acalabrutinib, and zanubrutinib monotherapy. So this is the typical scenario where NICE is trying to cut the price and the cost, basically, for acalabrutinib, I suspect. So watch the space. So that's kind of the first-line treatment. What do we do on top of that? Of course, we have to manage the immune system failure. I already talked about the autoimmune complications, but the other main problem are the infections and recurrent infections. And obviously, as patients, you're all aware of those complications. So we do really recommend vaccination, pneumonia vaccination. There is a special schedule that needs to be repeated every 5 years. The shingle vaccination, it has to be the recombinant vaccine that is an inactive vaccine and that is safe and effective. So not the active vaccine. I think the active vaccine is being taken off the market and being replaced by this one, but it's always worth mentioning you want a recombinant vaccine. Of course, flu and COVID, and then hepatitis B vaccination is always advised, the diagnosis, if you have not had any exposure to hepatitis B. It's important to avoid live vaccines, MMR, yellow fever, oral polio, and then, like I said, the Zostavax, which is the shingle, the active shingle vaccine. And then avoid the close contact for 7 days with anyone who's just had nasal flu or oral polio vaccines. It's okay. It's good to stay socially active. I think it's really important that you're choosing your contacts wisely. So if you love going to the theater, please go. But at the same time, if you hate going to the theater and you're only doing it because your partner wants you to, then you have a good excuse to say, I can no longer go because I've got CLL. So choose your battles wisely, but try and stay socially active, because this leukemia is called chronic lymphocytic leukemia. The emphasis is on chronic, and we can't get rid of it completely. That would be really nice, but we can't. So the immune system will get progressively worse, but you also now have a life expectancy that is very close to anybody else's, and you can't keep yourself away from social interactions forever, because that destroys all your quality of life. So it's important that you choose, carefully what you can and can't do, what you want and don't want to do. This we've already talked about. These are the autoimmune complications. I'm not going to touch on that much more in the interest of time. If the CLL comes back, so this is not the end of the world, because they are very effective next options. And so maybe the CLL will come back after 5 years or after 7 years. If the CLL works, if the treatment has worked well for over 2 years, which is the case with many of the targeted therapies, it can actually be repeated, the time-limited therapy. In some parts of the world, it can be repeated. In some parts of the world, like in the United Kingdom, there are restrictions on that, and we can't do that, and that's a bit silly. And we're having ongoing discussions with the NHS to tell them that is actually quite silly. Now, if you have been, the principle really is that if you relapse from one drug, you switch to another regimen. So if you were on a BTK inhibitor in frontline, you then switch to venetoclax-based regimen. If you're double refractory, then that is becoming a bit more difficult, but pirtobrutinib is one option where we have data, and that's why it's recommended in the guidelines. But clearly, clinical trials at that point in time are also important. So there are 3 different scenarios. The first one is that you've had chemoimmunotherapy, and a lot of those patients are still around. So they've had chemoimmunotherapy, then maybe they had fludarabine, cyclophosphamide, and rituximab. 10 years ago, they've been in a really good remission, and now it's time for more treatment. So the options here are either 24 months of venetoclax and rituximab, or continuous zanubrutinib and acalabrutinib. And there's very good evidence for both of those in a setting where patients previously had chemoimmunotherapy, because those were the patients that were around when those drugs were developed clinically, and the clinical trials happened in the relapse setting. The second scenario is that the relapse happens after continuous BTKI. So here we need to decide between 2 scenarios. Either it's a proper progression, which means resistance to BTKI. And if there's need for treatment, then again, it's venetoclax and rituximab, or it's switching to a non-covalent BTKI, such as pirtobrutinib. Both of those options work. The advantage with a non-covalent BTKI is that, yes, it might not work that long, but even if you get only a couple of years out of it, you can then go to VEN-R after that, right? So you're having you're sequencing in that way. You could also sequence the other way around. And we don't have good evidence for sequencing. And this is one of the areas where we're gathering, real world evidence. And then the other scenario is that it's actually that you didn't relapse with a covalent BTK, but maybe you didn't want to take it anymore because you're intolerant, because you get lots of joint pains, or you've had bleeding complications, or that the headaches I was talking about earlier. So in that case, then you switch to Förner and or an alternative covalent BTK or non-covalent BTK. And personally, I would always try the covalent BTK first, because as I said at the beginning, there's little cross reactivity when it comes to side effects. So it's definitely worth switching to another covalent BTKI. And then there's the third scenario, which is the relapse after venetoclax-based treatment. So these are the usually the mostly the fixed duration therapies. And here, as I already said, we can either say, okay, it's an early relapse. In that case, you switch class, so you go for continuous zanubrutinib, acalabrutinib. Or you go, if it's over 2 years ago, you can treat with Förner, or you can treat with, again, continuous therapy. The patients with double refractory CLL should receive a non-covalent BTKI, and that is mainly as a bridge to something else, to some more definite treatment, or to a clinical trial. But the reality is that because these drug combinations are so effective, very often you will find, that this event from being diagnosed to needing treatment, to then having the first treatment, then having the second treatment, is actually covers a period of 20 years. So we're talking a long time here, and very few patients these days actually have proper double refractory CLL and need more definite treatment or clinical studies. Okay, so last but not least, the Richter transformation. This is very rare. It happens in about 2 to 10% of patients. And it's basically that the CLL transforms into a more aggressive diffuse large B-cell lymphoma, a different type of lymphoma. And the warning signs for that include sudden fevers, rapid lymph node growth, or feeling much more unwell. And it requires a biopsy of the tissue sample of those lymph nodes to confirm the diagnosis. So the diagnosis cannot be established just with a blood test like you would do with CLL. And it's treated as a high-grade lymphoma. So usually the backbone of the treatment is chemoimmunotherapy. But we know that all the available options we have are not very good, and we basically need to find newer treatments and better treatments for Richter transformation. So most of the time, what we try to do is refer patients to bigger centers where there's a lot of clinical trials, where they can access studies for this very rare complication. So what can patients themselves do? Obviously, making sure they stay active, they eat well, exercise is really important. Manage fatigue. Sometimes difficult to see, is this a CLL or is it just me getting older? Is it the tablets? So it's trying to understand where the fatigue is coming from, but then also pacing yourself is important. And I think that can also actually improve your quality of life in sometimes if you can live a more mindful way where you would pace yourself and you take things a little bit more slowly. It's important to protect your skin. Patients with CLL have a 20 times increased risk of skin cancer. We don't really understand why, but it's important to take sun protection. As I already said, social contacts are really important, and talking about about your feelings with loved ones is very important as well. So this is the. I just put this there for the Richter's transformation. I don't think we have to go through this in detail. It just highlights the importance of the clinical trials as a way to trying to find better treatments for Richter's. Okay, so I think I stopped there, and I hope I can answer any questions.
Thank you, Anna. Thank you for a very neatly translated top line of the guidelines. And I would say to anybody else that if you want to read the guidelines, there's a lot of clinical detail and jargon in there, but guidelines are very evidence-based. So everything that has been decided with the guidelines is based upon the strengths of the evidence. So please, if you feel you wish to, visit the guidelines to make yourself familiar, and that explains why, for example, fixed duration treatments are preferred as a primary option, first treatment to a continuous therapy. There are a few other reasons, but what's really clear from the guidelines, isn't it, that decisions are made by a cluster of factors. So, and the guidelines have got a more of a patient-centric and a holistic approach to how decisions are made. I was just going to ask you a quick question before asking some of our advocacy panel. Anna, how close do you think we are to a true personalised approach to a care model in CLL? Is that something that you feel that you can answer?
Yeah, I mean,
unfortunately, with your
the
camera,
way I look at it.
bits. There we go.
Okay, I put the camera back up. Yeah. So with your, I think the biggest gap to personalization is the problem of being able to predict whether people need treatment or no treatment. That's one big gap. But the other big gap is whether what we can do about the progressive immune suppression. And so that is where I think personalization needs to come in a lot more, because there's clearly some patients who fly through all the treatments, they never have any problems with infections, and they're totally fine. And then there are others who already present with infection, even before the diagnosis of CLL. You ask them, they've had a long history of infections and recurrent infections, have never been diagnosed. So, and we don't have any tests that predict, what the immune system, in which state the immune system is. So I think that's definitely an area, because that would then also define, maybe the type of treatment that patients need. I think the other area, the third area, is this whole question of measurable residual disease and treatment duration, how long you need treatment for. So we have made a lot of progress on that in the United Kingdom with the FLAIR study. And in a nutshell, I think what this study shows is that actually the best, if you don't want to personalize and measure the amount of CLL left when you give ibrutinib and venetoclax to people, then you should probably give it to everybody for about 2 years. But there are some people who probably only need 6 months. And then there are some people who probably need 3 years and not 2 years. So there's room for personalization in that space, but at the end of the day, it's like, is it 6 months of treatment or 3 years of treatment? I think the bigger question is how can we prevent immune complications and infectious complications, and can we identify some patients, very few patients who might benefit from earlier treatment, but then also reassure a much larger proportion of people and tell them you don't need any treatment, you will never need treatment. But for that, you need to have really good tests and be certain. And that's the challenge at the moment.
Thanks, Helen. So we're not there yet, but we've certainly got a different picture to what we had 10, 15 years ago. And there's a lot of space, a lot of optimism and hope for patients that there are stepping stones to take you through towards end of life without the CLL taking your life. And I think
and there's lots of, we have lots of choices now. This is, I think, a big choice for patients is this fixed duration versus unlimited, but also the IV versus tablets. There are big choices, that patients never had before. In the era of chemotherapy, there was no choice in that way.
Thanks, Anna. And I just finishing off on that, I guess with regards to the immune system challenges, you mentioned earlier, 2/3 of patients are diagnosed asymptomatically, and there's a lot of uncertainty involved with that, but that's when people's immune systems are probably at their most intact. So the section within the guidelines that focuses that you top lined there with regards to aspects of healthy living, but more importantly, the vaccination protocols and everything else, that the active monitoring period is an important management period, because it also offers the opportunity for patient empowerment, for learning, for and making sure that those protective measures have been put in place. I'm going to throw a question out to our panelists. And Anna just kind of touched on it, and it was there on a couple of the slides as well, because, when you're making decisions, when you've got options, when you can make choices, and there's the patient preference bit, understanding what a treatment of fixed duration really means to your day-to-day activities, quality of life, and what that would involve and how it impacts versus a continuous therapy. But I'm going to ask the panelists, if I went to you first, Johannes, what issues matter most to patients, do you think, that are sometimes under-discussed in the clinic, and maybe also under-discussed at that point of making a decision? And if the question is too large, why do you think?
So I'll give it a shot, Nick, and thanks for the question. This is really relevant, and these are topics that are coming up regularly in our patient support groups. Patients usually think that their personal well-being and the way they live with CLL is underestimated by the clinical community. So they think the doctors are just worrying about blood values, biomarkers, medications, and their clinical guidelines that prescribe certain therapies for certain subtypes of CLL. But I believe what we've just heard from Anna actually tells us that the contrary is true. Looking at the new EHA CLL guidelines tells us actually that doctors are trying to look holistically at the patients and are going away from trying to treat the disease only to a situation where they treat the patients with all the questions, with all the psychological implications, and with all the quality of life questions. So that's what I'm usually getting from patients, and I'm wondering if there's anyone else in the panel who wants to expand on that and add some other points of views.
Well, I can perhaps add something. The first is that I am very satisfied that this guidance, extremely precise, rather complex, I must say, but it's the way it works now. I think guidelines 10 years ago would have been more simple, and it's a good point that the guidelines are becoming more complex because there is, as Nick said, and Anna, of course, a holistic approach. On part of it is the preference of the patient, in some case at least. So I think that our role as advocacy, as you said, Johannes, we can't expect, I think, that all patients are aware of those very complex guidance. But our role as patient advocate, is to integrate those guidance in order to be able to answer the questions of our patients.
Very good thoughts, Pierre. Very, very good. Rita, did you have any thoughts on that?
Yes, I actually have some questions for Anna, because some things are not that sure for me. I know the guidelines are very exact and very correct, and I'm thrilled about that we are getting that to understand that patients can understand it also in a way. But it's not that in real life it's not the same. But that's another issue. But my question is also because we are talking about quality of life, and that is a big issue for the patients all the time. And they have many questions about it because they are not allowed to go this and there, and infections here and there. Should we have a guideline about vaccines or how to get there? Because the quality of life is very important. You can get there with grandchildren and so on, but it's very unsure for many patients to get there because they are getting in the kindergarten and getting all the diseases, and they are coming home. So I have actually some questions about that. How should we have guidelines for our patients how to react in daily life?
Any thoughts, Anna?
Yeah, maybe I can. Maybe I can start off with that. I think it's very difficult, and I think this is what I was trying to say. You know, if we had a really good test, something to measure how good the immune system is, we would be able to give patients a lot more guidance. But in all the years, even despite of COVID and everything, we don't really have any good tests in the clinic. There's lots of complicated tests in research, and then we have in the clinic, we have we measure the amount of immunoglobulins that are in the blood, but that's a very imprecise test. And there's patients who don't have many immunoglobulins, and as a general rule, they do a bit less, but they do less well and they get more infections. But there's many patients with normal immunoglobulin levels and they still get infections. So it's not a very good test. So without the test, without any data to kind of come up with guidelines is very difficult. I think we have learned from the COVID pandemic, certainly. You know, I should say for myself personally, I think I probably was very relaxed before with patients. I basically told them, you have a chronic condition.
We've lost you, Anna. I think we got the gist of what Anna was about to say. Before the pandemic, she was relaxed, but then that soon opened the eyes, and it also opened the door to research.
I still disagree.
We're losing you, Anna.
Oh, sorry.
We missed a little bit.
Yeah, it's hopeful. Yeah, hopefully it's coming back. What I was saying is that I think that so number one, the issue is the lack of tests and the lack of data we have. We have relatively good data on COVID during the COVID pandemic, and we know that COVID is a particular issue. We know that flu is a particular issue for patients with CLL, and that's why we are encouraging vaccination. But we don't really understand, you know, why some people get hospital-acquired pneumonia, community-acquired pneumonias and recurrent chest infections. We don't understand this well enough, and I think a lot more research probably needs to be done. Now, in the absence of that, like I was saying, I don't think we should be as restrictive as we are with bone marrow transplant patients. And I think sometimes when I'm reading through nursing, especially nursing advice, or some of the the general hematology advice that for hematology patients, it's too restrictive for patients with a chronic disorder, because you have to live with CLL. You know, when you've had a bone marrow transplant, is a different situation, because you're basically trying to survive a disease that will otherwise kill you within 6 months. And then you have a limited period of time, maybe 6 months, maybe a year, where you're very immune suppressed. So that for that period of time, you can be very restrictive. You can tell patients, oh, you must not eat cheese, and you must not go and see your grandchildren, and you must not do this and this and that, because it's a very limited amount of time. But with CLL, you can't do that, because people have to live. Mm-hmm. And so that's really why we need, I think, you know, we need, you know, a better approach to this. But I don't have a good answer, because we can't back it up with data. And that's, I think, is the problem here. If we don't have data, you can't write like very precise guidelines. So what I usually tell my patients is that, yeah, is exactly what I said there. If you don't want to go to an event, you have a party coming up and you hate the guy, don't go. You have a good excuse. But if you really want to go to your best friend's birthday party, please go.
And take precautions.
And I know this is, and take precautions, and whatever you feel comfortable with. It's terrible not to be able to give you a more precise answer, but I just wouldn't know how to do it.
Maybe I have a
because
suggestion.
we haven't got the data. Yeah, go on.
Thank you, Anna. I have a suggestion because it kind of segues onto a question I was going to ask. Is how can patient input make the biggest difference? In contributing to guidelines, and obviously evidence generation and evidence is what has to be behind everything. So what should or could future guideline groups do to make patient involvement even more meaningful? I think that could start first with the advocates. And Rita, you're actually involved in the CLL immune compromise, CLL immune compromise task force, where we have an initiative at the moment where we're working with the entire stakeholder group globally across immunologists, hematologists, the MDT, patient advocates, and we're creating educational booklets to help patients live life, but also navigate their immune challenges, aren't we? Maybe there's a way that we can add the evidence to that as well at some point on improved outcomes of patients so that can be incorporated into guidance. But maybe future guidance, we can start signposting to these practical tools to help patients with navigating. Because that's exactly what Anna was bringing up, isn't it? You need the social contact. Don't isolate yourself, because the impact on your mental health is going to be worse than in many patients of the risk of infection. But if you don't know what your risk of infection is, that's part of the problem. So I'm going to ask that question. In general, obviously, I'll make a comment that there's a lot more room in the guidelines to include elements of survivorship and practical day-to-day aspects of how to advise patients on day-to-day living. So how can patient input make a bigger difference, do you think, to be able to work in these spaces? And I'd offer that to you, Anna, first, and then I'll offer it to the panelists.
Yeah, I mean, it would be such a good idea, to be able to have a survey and to say, with the right questions, to say, what does a daily life of a CLL patient looks like? And I'm sure you'll find like a really big variability, of people who do everything and live a completely normal life. And then there's others who will be completely isolated and they never go out and they always put a mask on. And so, but to be able to capture that variability, I think would be a first step in the right direction. If we can capture the variability, and then even better, so maybe say, how many times did you need antibiotics in the last 6 months? Being somebody who doesn't care and just lives a life, and some other people, who might still get infection despite the fact that they are very vigilant. How do you use hand sensitizer? There's something. Do you see your grandchildren regularly? How often do you ask whether somebody has an infection before you meet with them? There's so many questions that you could ask and find out what is their behavior, what is people's behavior on a day-to-day basis. And then if you do that for 700 or whatever, 500 people, I'm sure you might see like some patterns emerging.
Thanks, Anna. Anybody got any thoughts on that? Johannes,
do you experience more infections while they are treated? I'm sorry, I interrupted.
So that's also an interesting question that we're trying to understand. Actually, in Carsten Niemann in Copenhagen, he ran a study looking at this, and it looks like it's in the first month or so of acalabrutinib, venetoclax acalabrutinib, that you get more infections, but then after you get less. So the immune system, and that's definitely also what we always observe, as clinicians who've been around for a long time, is that very often the time of treatment coincides with the CLL becoming more active and the immune system being not in a good shape. And so patients often associate the treatment with infection, but it's basically the infection is probably there before. And so you have a month or so for the treatment to kick in and then to really improve the immune system. And then after that, the infections get less again.
Okay, thank you.
Thanks, Anna. Johannes, Pierre, have you got any thoughts?
There's something I'm happy to add, Nick. I completely agree with Anna. We need more real-world data in order to analyze where this is coming from and take the opportunity to integrate them into some patient-facing, patient-centric guidelines, if you will. I think the problem is about to be partially solved within existing clinical trials. And I give you an example of mine. I started a clinical trial in 2022, and the trial protocol records some of these data, not an awful lot. It's very, very coarse, very, very rough, and doesn't go into much detail. I think what needs to happen, we need to get smart IT and maybe AI support in the form of an app or computer system or whatever it is that allows patients to record these data themselves on a daily, weekly basis whenever this comes up. I have not found anyone yet who's willing to take the opportunity, and maybe that can be the role of a patient organization like us, Nick, to sort of create something very simple which allows patients to record their well-being, what they did, who they visited, what infections, what frequency, and this sort of thing. And if we could provide this data then to clinicians and professors like Anna, who could make some sense out of that, maybe that could help us progress the issue.
That's really good thinking. And I think the other thing that's a challenge, for example, the CLL Advocates Network, we're launching in the first steps at the moment of creating the question sets and the methodology behind our next global CLL patient experience survey. But human nature, when people fill in these surveys, it's a moment in time when they fill them in. Yeah. And as human beings, a couple of weeks after we were poorly, we've forgotten what it was like to feel like when we were poorly. We can't remember what we ate on a Monday, on a Friday, you know. So I think this is a really relevant point. People complain about the amount of words, the word limits, or the amount of commentary that we can get into guidelines around supportive care, around day-to-day living, around survivorship aspects, behavioral patterns to follow, and advice and guidance in that respect. But without the evidence, we're never going to get them in there. Yep. I think it's something to think about for our next survey. Pierre, did you have something?
If I may add something, well, I think CLAN is very active in both consideration about immunity. You mentioned that, Nick, with all experts, all stakeholders, etc. It might bring some information extremely relevant. The surveys as well are providing data, because if you are thinking about artificial intelligence, it needs data, of course. But at the end of the day, as Anna mentioned, it is the responsibility of the patient to take to choose the way he wants to live. But in order to take this responsibility, he needs information, and that's our job.
Very good point, and that leads me to what's in a word: watch and wait, active monitoring and active surveillance. 2/3 of patients, or the majority of patients, spend a lot of time on active monitoring before their first treatment. You go back onto active monitoring again after treatment. You know, that time needs to be used widely, and as patient advocates and as a clinical community, we need to help patients use that time to empower themselves through learning, through behavioral changes. And if we can get some evidence behind changes in behavior and their impacts on people's quality of life and lived experience, and that's going to make a lot of difference. I'm mindful of time, and I'm just going to look to the audience, really. Thank you, everybody, for being with us. Are there any questions in chat that anybody have got whilst we've got our esteemed panel? I'll just have a little scope. Any questions from anybody? I'm giving you the opportunity. Otherwise, I could fish another one out. I guess one of the hot topics at the moment is shared decision making. There's been a movement going in this direction for some time, and there's two pillars of empowerment, aren't there? The treating physicians need to be able to offer and build that relationship of trust and be able to communicate with their patients at that level. But we definitely have to help empower patients, even if it's health literacy or understanding, to be more empowered, to be able to balance those, when patients have got preference, to have the confidence to do that. So I was going to ask Anna first, do you have any thoughts in this space about how you approach discussing treatment choices with your patients and patient preference, and any barriers you find, and any thoughts that you have from your side, and then we can ask the same of patient advocates.
Yeah, I mean, it's a very important question, but I think it's exactly what you said. It's about establishing a relationship of trust, and how you do that is, yeah, I think you can learn it, but there is something that as a doctor you have to just be able to do. I mean, I don't think I'm a bit old-fashioned in this, but I do think what Johannes said at the last, I can't remember whether it was the German study group meeting or what other meeting it was, I can't remember now, but it's basically about patients teaching doctors, and I think the patient teaching doctors is an important thing, and to empower patients to have the courage to basically say to a junior doctor or to a professor, you've just said something that was not right, or you just said something that made me feel really bad, or it made me worry a lot, or can you please say this in a nicer way, or I didn't understand this, just make it simpler. That to be able to say this, and I know this is very difficult, because I know, like, I have this with my students as well, that they never want to say what they really think. But we are there to be, by we I mean doctors, professors, junior doctors, we are there to be challenged. So you need to, I think, this relationship of trust is it works in both directions. It's not just that you trust us to give you the right treatment or the right information, the right advice or whatever, but it's also like, you can tell us wrong and we will still be with you. You can criticize it, but we're not going to drop you like a hot potato. And I think it's that vulnerability that you are in as a patient, because you think, oh, I can't say anything against my doctor because I can't criticize him, I can't ask questions because I'm depending on him, right? And we need to get away from that sort of power dynamic to a relationship of trust. And that's something that only patients ultimately can tell our doctors, whether they are old or whether they are junior doctors or whatever they are. So I would encourage you as a group to think about that more carefully, how you can, and I'm sure it'll be quite successful probably, because there are probably lots of doctors out there who struggle with this. And if you can come up with a consultancy, project where you give 2 hours of consultancy work on how to talk to patients, to doctors, I'm sure people would subscribe. I mean, I'm just kidding, but I think it's very important. It's very important to get this out there.
Thank you, Anna.
How you establish a relationship of trust.
Yeah, and I think that's building relationships when you live with a chronic condition. You can have a chronic relationship, It's got a chronic
It's so important. It's so important because, and you can see, or you can also see that, and this is why you have CLL doctors and they're specialists, because they are like GPs. They know like the old-fashioned GPs. They have got patients who they've seen for 20 years. That never doesn't happen with transplanters. It doesn't happen with many of the high-grade lymphoma patients, because they're cured, you discharge them, you never see them again. So it's very different relationships, when you're dealing with a chronic disease, it's very different. And that's why I think sometimes also when patients are seeing non-CLL specialists, then it becomes more tricky.
Yeah. So continuity of care is really important. So as patient organizations, we have a responsibility, and we have the capacity there to help with empowerment through peer-to-peer resources, peer-to-peer support groups, learning materials. But, ultimately and that's why perhaps active monitoring is always a great period for empowerment, because it can be a lengthy period, and some may never need treatment, and that's where you learn from other people. But Pierre, I noticed you've got your hand up, and then I just wanted to go to Jennifer, who's asked a question in chat.
Okay, hi, just very, very shortly. Anna, if you say you are old-fashioned doctor, saying what you have said proves that you are not. But I would mention what we are doing in France with ELI, our association. We are participating in training of hematology students. Especially, we are playing the patient, and they are playing also the doctor during very critical phases like diagnosis announcement or the treatment choice. So we are trying to do a little bit what we are saying, Anna.
Yeah, that's excellent. I mean, I'm not a friend of role modeling, but that's because I'm old-fashioned. But I do think it's I think that it's exactly what is needed, and I think it's more needed than in the past, because doctors, the training of doctors. I actually worked in France a long time ago, for some time. The training has become more theoretical and more in the whole of Europe for reasons to do with European directives and everything. So there is a reduction in the time where you can practice continuity of care, and I think that's it's a real shame. And it's because it is something that you can only learn from practicing, and you can't learn it from the textbooks and from theoretical sort of seminars.
Thanks, Anna. Just going to go to Jennifer's question, which I was going to ask about earlier, about limitations or misconceptions that people might have when a patient first reads CLL guidance, and Jennifer's question is really interesting, because it's about patients treated maybe in rural areas in hospitals that aren't larger academic centres, and maybe don't have access to a CLL specialist. It might be a general hematologist that's treated, or with good depth of knowledge in CLL. But and guidelines are always aspirational; they're state of the art. But how do we? What are your views on that question? Don't know if you've seen it from.
Yeah, I mean, the bottom line is that we know that patient satisfaction, even CLL outcome, so overall survival, is better in when you're being looked after by CLL specialists. I'm sure that applies also to other hematological diseases. So it's an incredibly complicated field, hematology, and we are all super specializing in a few disease areas, and we don't really look after everything. When I'm saying we, it's the people who are writing those guidelines. Then there is a whole army of hematologists who have to do everything. They look after the transfusion laboratory. They look after patients with inherited anemias, and then clotting problems and vein thrombosis, and then they have acute leukemias, and they have so many different aspects of types of patients they need to look after in smaller centers, and that is where the challenge is. So to keep up with even I'm not even saying keeping up with the latest literature, just keeping up with the latest guidelines will be difficult. So again, the role of the advocates is to ensure that the patient feels empowered to remind the doctor of, oh yeah, have you seen? There's the recent EHA guidelines. I can give you a copy. Because once they know and they read them, they understand them straight away, right? It's not like they don't understand. It's just that they haven't seen them. And I think it's important that you feel like you have the right, as a patient, you have the right to show this to your doctor and to say, in the nicest possible way, this has just come out, I've heard about it, what do you think? Shouldn't I be on this treatment? I'd really want to discuss whether I really have to be on the tablets all the time, because I'd much rather have a treatment only for a year. Is that possible with my type of CLL? You can ask those questions. You should be able to ask those questions. If the doctor reacts, not nice, then it's not that's not your fault. That is then a problem with the doctor.
Thanks, Anna. It's a valid point. And maybe, a role for us as advocates, as patient groups, is to make this information more visible. Maybe in the future also look towards a little bit of translational version into more lay language as well for patients, so it's easier for patients to be able to read or understand with some top-line information like you just provided. But I think I'm mindful of time. We're going to have to draw things to a close. And if I was to sum up, I think we're at that place where we need to work together as patient organizations, patients together, to help empower patients, work with the clinical community to create the evidence we need to. So that patient centricity, is actually fulfilling that role, because unless we carry that forward together, then these areas aren't going to be addressed. And so some really interesting ideas have come up today. What is without a doubt, some of us that have lived with CLL for some time, it's so exciting just to see, if you're an advocate, just what treatments and how much hard work and evidence and knowledge has grown to create the treatment algorithms that are available now to extend survival. Now we need to extend, as Rita was talking about, quality of life, impact on daily activities, impact on your experience. That's the bit we now need to get hold of. And that would be my summary on that one. And I'd just like to thank everybody for joining us today and our esteemed panel. And I'd like to thank EHA for opening the door to allow the start of this process, because it's a chronic condition. We'll get to a cure one day, but it's not going to happen overnight. And I know Anna's working on a few ideas. And we're not going to get there immediately with building our relationships with the clinical bodies and associations, but by working together and gaining each other's respect and delivering, we will get there together. So thank you, everybody, for joining today's webinar. And thank you for all of your hard work.
Thank you.
Thanks.
Thank you.
Thanks.
Thank you.
Thank you.